Okay, so picking up with the respiratory system, and we're now in that lower part of the respiratory tract, looking at the respiratory zone. The respiratory zone is where gas exchange occurs. So we're down in the alveoli, and that's how you pronounce that, alveoli. And those are the tiny little air sacs that are made up of simple squamous epithelial cells. And they're so very thin for rapid gas exchange. And they're surrounded by capillaries, which we call pulmonary capillaries, which receive the oxygen and dump off the carbon dioxide to the alveoli. So when we look at pulmonary capillaries, they're also very thin, simple squamous epithelium, because we want this carbon dioxide and oxygen to diffuse rapidly across that membrane. So as air comes down into the respiratory zone, it comes down via the bronchi, and then the secondary bronchi, and the tertiary bronchi, and then it branches over 20 more times to get to this final passageway, which is the bronchiole. And the bronchiole is surrounded by smooth muscle, so that's the only thing that keeps it open. So if smooth muscle constricts, that's going to impair airflow, right, in and out of the lungs, in and out of the alveoli. So if a person has an allergic reaction, like a peanut allergy or some severe anaphylaxis, you know, that can happen. Anaphylaxis is the fancy term for just system-wide allergic response. That can impair breathing and cause death within minutes. So really, really important if someone has an allergy to something that they know can cause anaphylaxis, that they carry their EpiPen and take the time to do that. People say, oh, it's so expensive, and they are expensive. If you do your research and talk to people, talk to pharmacies, some have coupons. You can bring the price down to about $100 a pen, but you have to do some research and be creative with your coupons on that. But anyway, if it constricts, very dangerous. If it dilates, we can breathe much better. So epinephrine, what do we know epinephrine does to the airways? Does it make breathing easier or harder? Epinephrine, which is part of the sympathetic nervous system, which is the fight or flight. What would this body want to do if you need to fight or flight? Breathe better, right? Yeah, so that dilates smooth muscle of the bronchioles. So that's why we take epinephrine, right? EpiPens are epinephrine. So that dilates those bronchioles to allow us to breathe better. So here's the pulmonary capillaries. So this would be a branch of the pulmonary artery, right? The arteriole coming from the pulmonary artery, and then it becomes pulmonary capillaries. Then it turns red as these capillaries pick up oxygen as it diffuses out of the alveoli into those capillaries, and then it returns back to the heart. This will eventually lead to the pulmonary vein to the left atrium. So this is where the exchange occurs. Remember, capillaries are the exchange vessels. So because carbon dioxide and oxygen are lipid soluble, they just diffuse straight across the membrane. Diffusion is the means of transport for these gases. So, but we have to have these open airways in order to get them into the alveoli. So anybody with constricted airways is going to have trouble inhaling and exhaling because it's the same passageway in and out. So the respiratory membrane, if we slice this pulmonary capillary and alveoli in half and look at it in a cross-section, here's the pulmonary capillary that has red blood cells in it, right, that deliver oxygen and carbon dioxide. Remember the hemoglobin molecule present inside those red blood cells? And then here's the alveolus. So we can see the simple squamous cell here of the pulmonary capillary and the simple squamous cell of the alveolus. So we call this little two-membrane barrier, we call this the respiratory membrane. So on a test, if you're asked what makes up the respiratory membrane, the answer is the pulmonary capillary and the alveoli. Those walls butted against each other makes up that respiratory membrane. So this is part of external respiration as air enters the alveoli and then travels to the blood, right? So oxygen is here, it's going to travel to the blood in that pulmonary capillary. So we always know that we have a higher concentration on one side of our membrane in order for diffusion to occur. So we have more oxygen in the alveoli, so that pushes it to the blood. And we have more carbon dioxide in the blood as a result of metabolism, and that pushes it to the alveoli. So we call these partial pressures, because these are gases. We use the term pressure when we talk about gases. So the partial pressure for oxygen is higher in the alveoli than it is in the blood, so it diffuses into the blood. Partial pressure for carbon dioxide higher in the blood, pushes that into the alveoli. So down here in the alveoli, what do we have? We have different types of cells. We have these type 1 alveolar cells and type 2 alveolar cells. So the type 1 alveolar cells are just simple alveolar cells that are the brick and mortar of the alveoli. It's like a soccer ball. Each little hexagon on a soccer ball is an alveolar cell. It's a type 1 cell. Its job is just to hold that alveoli together, just to make up the walls of the alveoli. The type 2 cells are special cells that secrete a substance called surfactant. And we'll talk about that in a little bit. But they have a special job of secreting a chemical called surfactant, which keeps the airways open. Or not the airways, the alveoli. And then we have these macrophages. So these are little immune cells that chew up bacteria or fungi, any kind of spores we may have inhaled. They keep our lungs clear. So when you exhale about 2 million dead macrophages every hour in the air that you're exhaling. So they play a really important immune function down in the alveoli. Because down in the alveoli, there is no cilia. There's a limited amount of mucus, so we need these macrophages to keep us healthy in the lungs. But these macrophages can't keep up. If we inhale food or saliva on a regular basis into our lungs, even little bits of food or beverage, that's going to cause pneumonia and infection in those lungs. So when we have this special substance called surfactant, what it does is it reduces the surface tension of water, kind of like detergent can break down oil, and results in a little soap bubble. So surfactant, so this whole alveoli is lined with water, and water wants to form a water droplet, right? Water likes to stick to itself. We call that surface tension because of the polar covalent bonds that we see and the hydrogen bonding that occurs between water molecules. Again, it causes this attraction. So the walls of the alveoli want to collapse with this water film that's inside of them. But surfactant breaks that bonding and keeps those alveoli open. So how do we increase surfactant production so we keep our airways open? Deep breathing. When you expand your alveoli, it stimulates those type 2 alveolar cells to secrete more surfactant and keep your airways open. So those of you that have worked in healthcare or been a patient yourself, you know that when you breathe in your incentive spirometer, right, that little chamber they give you with the hose on it, and you inhale, right, and you raise a little thing up, that's really important to give to all patients that are at risk of not breathing well after surgery, like abdominal surgery, lung surgery, heart surgery, or pneumonia. When they're not breathing and taking deep breaths, surfactant levels are going down, and those alveoli start to collapse. And they start to collapse first in the bases. Because when we're breathing, just to maintain life, we are expanding the alveoli in the upper airways, or the upper portions of the lungs. But to really get those lower alveoli expanded, we have to deep breathe. So you guys, when you're sitting in class and taking a test, like a long test, like when you're taking your certification exams, maybe if you're taking the NCLEX, you really want to practice deep breathing and making sure you're keeping your alveoli expanded and doing deep breathing exercises and telling our patients to do the same thing. That's why we have them sit upright in a chair. You're more likely to deep breathe and expand those lungs when you're sitting upright than you are laying flat on your back on a bunch of pain meds, right? So it's really, really important that they get that deep breathing in. So surfactant is the name of that substance, and deep breathing is what stimulates it. When babies are born too early, before 34 weeks, they don't have enough surfactant production, so they will actually give the mother some steroids via injection, and that will speed the lung development of that baby. It'll help increase surfactant production. And the squeeze of a baby that's coming through the birth canal in vaginal births, that promotes surfactant production. That squeeze, that pressure on that chest cavity and in that lung tissue stimulates those type 2 alveolar cells. Or when they're born and they cry. Some in the old days used to slap the baby on the butt if it didn't cry right away, right? So they think crying actually helps surfactant production. But if a baby is born peacefully and calmly, like in a water birth or something, they'll be okay as long as they're full term and nobody's concerned. But sometimes babies get a little fluid in their lungs and they need to be suctioned. It's always something that they monitor how the babies are breathing when they're first born. But babies being born via C-section that aren't squeezed and they just are lifted out, sometimes they need a little extra support in breathing, getting them started. So when we talk about factors then that keep our lungs expanded so they don't collapse and prevent breathing, there's other tissues or other things we need to look at. And the connective tissue that makes up our lungs is stretchy. So it's elastic connective tissue. So that allows the lungs to expand when they fill with air, and then when we exhale, they go back to their resting length. So they're stretchy. We call that elastic recoil. So we'll talk about that in a little bit. But ventilation is the movement of air in and out of the lungs. We already talked about that. And there's a worksheet in your notes packet for the respiratory system. If you want to pull that out, there's a little chart in there. I'm trying to find where it is in my... What page is that on in your notes? What is it? 626. Now, this page number may have changed if you're viewing this in an online class, but it looks like this, so you'll be able to find it anyway. So these are all the definitions I have for all the lab objectives I talked about in the beginning of the class. So here's our worksheets. Getting to the end. All right, thank you. So this chart right here. So when we breathe, when we inhale, the diaphragm moves downward. So the diaphragm moves downward. What is that going to do to the volume of my chest cavity, my thorax? If the diaphragm moves down, it makes it bigger. Yeah, so the volume of the thorax, so the diaphragm moves down, so you're going to write the word down. The volume of you can just use up and down arrows too if that's easier. Just put a down arrow here. The volume of the thorax increases. So if I increase the volume, what does that do to the pressure of molecules bouncing around in that space if I make that space bigger? The pressure. It decreases the pressure, right? So if I increase the volume, that decreases the pressure. So what happens to the volume of the alveoli then? It's increased, right? Because those lungs are expanding. And which way does air flow? Into the lungs, because we have low pressure in the alveoli and we have higher pressure in the outside air. And the atmospheric pressure we just kind of set at a standard sea level of 760 millimeters of mercury. So that's not going to change. So we always want to have the pressure in the alveoli lower than the outside pressure to force air to come in from high to low pressure, right? So if we want air to come in, we have to decrease the pressure in the lungs. And how do we decrease the pressure in the lungs? By increasing the volume of the thorax. And how did we do that? By moving that diaphragm downward. And what also happens, that's not part of this table, is when we breathe, the external intercostals move the ribs up and out. And if the ribs go up and out, that further increases the volume of the thorax, which is further going to drop our pressure in the alveoli in the thorax, again causing that nice gradient from high to low outside. High pressure outside the lungs, low pressure inside the lungs. So the opposite happens when the diaphragm moves up. When we stop inhaling, we relax those muscles, the diaphragm moves up, and what is that going to do to the volume of the thorax? So diaphragm moves up, volume of the thorax is going to go in what direction? Down. So I'm decreasing that space. And what happens to the pressure of those air particles, molecules in the alveoli then? Increases. If I decrease the space, that's going to increase the pressure, and the volume of the alveoli is going down, right? So which way does air flow? Out. So if you think about the order of events, I want you to number these orders. This is the first step. The muscles have to contract. to get air moving in. So this is the first step, second step, third step, fourth step, fifth step. Well, I mean, the volume of the alveoli kind of changes with the volume of the thorax, so you could combine those two technically. But we have to contract the muscles to inhale. So that's the first step, contracting those muscles. If the muscles don't contract, then the ribs don't move out and the diaphragm doesn't move down. And we can't increase the size of the thorax to get that pressure drop. So these two things have to happen in order to get the pressure gradient for air to flow. All right, so back up to our notes. So Boyle's law relates pressure and volume, that if volume increases, pressure decreases, and if volume decreases, pressure increases. They're oppositely related, right? We call that an inverse relationship. So if we increase the volume, that'll decrease the pressure, because there's less bouncing against the walls, because pressure is force per unit of area of a particle in a container. So if we increase the area, that decreases the force, which will decrease the pressure. So we have some other things associated with breathing that are really important. We have these membranes. Remember the visceral and parietal pleura that we talked about in lab? Those are very important for allowing the lungs to, expand and then go back to their resting size. For breathing, they're nice and friction-free against our chest wall because of this pleural fluid that we have. So it acts as a lubricant, and it's like there's surface tension within that fluid that holds the parietal and the visceral membrane together. So when the ribs are moving out, the chest wall is going out, the lungs follow because of the stickiness of the pleural fluid. So it keeps those membranes together. Just like when you have a wet glass that's kind of condensing around the outside on a summer day on a glass table, and you try to pick it up, it sticks a little bit, doesn't it? That's just cohesion or adhesion of those molecules. So same thing happens with the visceral and parietal pleura. They kind of stick to each other because of this fluid in between them. So as long as we don't interrupt that space, the lungs will follow the chest wall. But what happens with surgery or a gunshot wound or a fractured rib that pokes into that space? That's going to separate that visceral and parietal pleura, and now the lungs are not moving with the body wall. What do we call that when the lungs don't move with the body wall? We call it a collapsed lung. And the fancy term for it, I want you to highlight this, is atelectasis. Atelectasis is the name for a collapsed lung. And that can happen as a result of surgery, because you're poking in those membranes doing lung surgery or heart surgery. We have to go into the mediastinum. So we end up giving people chest tubes, which creates a negative pressure, which keeps the fluid, the excess fluid, out of this space and restores that pleural membrane to allow that movement with the chest wall. So if we have proper placement of that chest tube, the person can maintain their lung function and not have atelectasis. It's excess fluid from surgery. No, it's just excess fluid that happens with. Right, yeah, no. But we need to maintain a negative pressure to keep that, to allow those membranes to be intact and move with the body wall. Yeah. It only takes a couple of days after surgery typically. So when you look at a person with bypass surgery where we had a cut through the middle, they have chest tubes typically that come right in the mediastinum, right kind of in the middle of the chest. And people that have had lung surgery are going to have it on whatever side the lung was operated on. So if we look at these pressures then, pressure in the pleura is always negative because we need that negative pressure to maintain that stickiness within that space, the pleural space. And you're going to get a lot more into detail with this in advanced A&P. So all you need to know is just that pleural pressure always has to remain negative. We don't want any positive pressure in there because that causes lung collapse. That separates the parietal and visceral pleura and causes lung collapse. So when we inhale, it becomes more negative because we really want that those lungs to go outward, and that's going to stretch, you know, as they move outward, that's going to stretch that pleural space. And if we stretch a space, but we don't add or subtract particles from it, that's going to drop the pressure. Anytime we increase the volume, it drops the pressure, right? So when we're inhaling, the body wall is moving out, and that's increasing that pleural space a little bit, so that pressure is becoming more negative. And then when we exhale, the ribs move inward, and that is going to increase the pressure in the pleural space back to that resting negative value of -5. So we can see how this moves oppositely, right? As volume is increasing, pressure is dropping, right? And then as volume is decreasing here, we can see pressure is increasing here. So they're oppositely related. So there's different factors that affect this process. The more stretchy our lung is, the more it recoils. So it's able to stretch outward and then go back when we exhale. That's called elastic recoil. So when we take a nice breath and then we exhale, it should drop back to its resting. So that acts inward. Elastic recoil acts inward on the lung, promoting exhalation. And surfactant promotes exhalation, right? Because surfactant keeps our, I'm sorry, it doesn't act inward. Surfactant keeps them open, so that acts outward. Surface tension acts inward because it causes lung collapse. We need a little bit of surface tension for those alveoli to get smaller and promote airflow out of the lungs. Pleural pressure, we always said, is a negative pressure. Compliance is the ability of the lungs to move with the thoracic wall. So if you have a nice stretchy lung that's not full of tumors or scar tissue, when you take a deep breath, the lungs go with the body wall. And then surface tension, like we said, are water molecules that line the alveoli, and that can cause the lungs to move inward. So if you think of forces that keep the lungs expanded and moving outward, it's elastic recoil and pleural pressure. So as long as we have that negative, that should be a negative number, so if you want to add that in front of this, negative pleural pressure is what keeps our lungs moving with the body wall and keeps the lungs expanded. Because again, if we break that pressure, visceral pleura and parietal pleura separate, and the lungs are going to collapse because of surface tension. So compliance allows our lungs to expand. But again, if you have a stiff lung from pulmonary fibrosis, or you have a bunch of fluid in your lungs, it's not gonna, you're going to have too much surface tension, and they're not going to follow the body wall when we inhale. And respiratory distress syndrome is in, you know, premature infants that are born too early. Their lungs don't expand as well and causes sometimes lifelong problems. People that are born really early often have lifelong respiratory issues. Okay, so again, the ability to expand is called compliance. Kind of think of it like someone says, come with me, and you go. Wouldn't you say that person is being compliant because they're going with who they were told to go with? So just think that the lungs, when the body wall is moving outward, when those external intercostals contract and pull the ribs up and out, if the lungs are able to follow it, we call that compliance. Now, people with emphysema that have blown out alveoli, their lungs are extra compliant because they have a hard time allowing the lungs to decrease in size for exhaling because they have these big air holes in their lungs where that alveoli have collapsed and been damaged. So they have like a barrel-shaped chest and make the sound of, like when I was picking up a kitchen table from somebody that had emphysema, he was helping us bring the chairs out, and he kept going, making that sound, because they have to add extra muscles to exhale because their lungs don't want to get smaller because there's no surface tension or elastic recoil to get those lungs to go back down when they exhale. Okay, so when the lungs are stiff, full of fluid, that's not going to allow them to expand and follow the body wall. Now these are the slides that we're going to save for advanced A&P. So we're going to cross out page, let's see, we're going to cross out Page 4. Let's see. Right now we're on page 438. We're going to skip to .442. So I want you to cross this slide out, cross this slide out, cross this slide out, and I want to just show you these two x-rays. When we take an x-ray, a chest x-ray, the lungs are simple squamous epithelium, so they don't really pick up a lot of x-ray. They should look a little hazy and very dark, so we should just see not much picking up x-ray. Here, look at how whited out it is on this side. So any whiteness is excess fluid, tumors, scar tissue. This is a really bad sign. This person has a lot of trouble breathing. They only have a functional right lung. So this is, in the case of fluid, we call that a pleural effusion, is when excess fluid fills the lungs and makes it really hard for people to breathe. Yeah, that would be difficult to breathe. Yeah, you wouldn't see anything here. It'd be completely clear. So if we look at this one, this person has a collapsed lung. Can you see the hazy connective tissue of an intact lung here attached to the body wall? Look at how dark it is here. So if you look at that person who did not have a lung, in your example, it would be really dark looking. Here we can see the lung is kind of collapsed along the midline. See that? So here's the lung that should be stretched out and filling this space. It's been collapsed and is along the midline. So it's much more difficult for people to breathe when they only have one functional lung. Here's the heart. So this is called a pneumothorax. When we poke into the space and the lung separates from the body wall, so that visceral and parietal pleura separate from each other, the lung collapses. We call that atelectasis, but that poke in the pleural space causing a positive pleural pressure in that pleural space between the visceral and parietal pleura, we call that a pneumothorax. And again, that can happen spontaneously, like really tall, thin, young males have spontaneous pneumothorax. Smokers with bad COPD and underlying lung disease can have spontaneous pneumothorax. Or, like I said, broken ribs, gunshot wounds, stabbings, those can all result in pneumothorax. Typically, it takes a chest tube placement to get them back into, because when it's completely collapsed, you use a chest tube to maintain that negative pressure till it heals. Because we've had patients hang around in the hospital for weeks waiting for that pneumothorax to resolve.
When I was 18, I had about a 24-hour period of time where I was only taking 4 to 6 breaths.
Oh, no.
I had no reason for it. I had no allergies. I didn't smoke. There was
Yeah.
no particular reason for it to happen. It just happened spontaneously. And
Wow.
I wouldn't say it went away spontaneously, but it went away incrementally.
It did.
Probably
Oh.
the additional 12 hours after the 24
Oh, really? Yeah, maybe it happens in a minor way in some people that resolves. I'm not sure.
And being a stubborn 18-year-old boy, I refused to go to the hospital.
Yeah.
That's conscious and still able to breathe at all, so.
Wow. Yeah, the spontaneous pneumos I've seen has been tall, thin. They get them numerous times and requires hospitalization. So when we want to measure lung function, we have people blow into a machine called a spirometer, and this measures the volume of air entering and leaving. So this little up and down here is called tidal volume. It's just the amount of air we breathe when we're doing quiet breathing, like when you're in class right now. You're inhaling, you're exhaling, you're inhaling, you're exhaling. That's about 500 mils. So it's called tidal volume. It's just resting breaths, about 500 mils. And this whole textbook is written on a healthy 21-year-old male. So these are the numbers they use. Now if I look at after a normal inhale, I can inhale a bunch more. We call this our Inspiratory Reserve. So what room is left for us to inhale additional air? Well, we have another 3,000 we can inhale. And that's important, right? If you're going to go underwater and take a deep breath and do some swimming, you're going to do that. Or let's say you just took a breath and then you yawned and took a big breath inward at the beginning of your yawn. Thank you for demonstrating, Sarah. And then when we exhale, at the end of a normal exhale, so here this person, took a big deep breath in and then out, and then a quiet breath in, quiet breath out. You can push out a little extra air, which is about 1100. We call that our expiratory reserve volume. So expiratory reserve volume. Notice it's much less than inspiratory reserve volume, because do we want to blow all the air out of our lungs? What would happen to the alveoli if we pulled all the air out? They would collapse. There'd be no air pressure in there, and they would collapse. That surface tension would push them, and they'd stick together. So we always have this residual volume here, which is leftover air in the alveoli and airways to keep our lungs expanded. We have constant gas exchange, whether we're inhaling or exhaling, because of that residual volume. So it's really, really important if you're a CNA to remind your patients to use the spirometer 10 times an hour while they're awake. I find a lot of patients have not been educated properly on that. They think 3 times a day is good enough, or maybe 3 times every couple hours. No, 10 times an hour. Do they have to do it 10 all at once till they get dizzy and pass out in bed? No. We just do it 10 times, like 2 or 3 here, maybe a couple here. And some are really motivated, and they're really working on it, right? But some patients, it's sitting out of reach behind them. They can't even see it, and they're not using it. Yes? 10 times an hour. Yeah, 10 times an hour. Yeah. And teaching them how to use it again. People listen and then they forget, and then they go to surgery and they forget. So we do a lot of our teaching on incentive spirometer before they go to surgery, while they're awake and they're feeling good, and then we demonstrate how they should do it, and then they have surgery and they look at how bad their results are. It takes them a little time to get back to normal. So again, just understand what these volumes represent. Just, simple definitions. And we can combine volumes to get capacities. So when it's called a capacity, we have to add volume. So what is the capacity of the lungs to take in air? Well, we'd take the 500 tidal volume and add that inspiratory reserve volume. Functional residual capacity is what is the capacity for gas exchange. That's where we add these two. Vital capacity is amount of exchangeable air. What do we have control over? So if I take if I blow all my air out and then I breathe as much air in, that's vital capacity. That's what I have control over. And then total lung capacity is something that is difficult to measure. You need, special equipment, obviously, because that residual volume, a portion of that is hard to measure because it's in the alveoli. We can't really measure that directly. So total lung capacity is just measuring all the volumes on that graph. So you're measuring this volume, and this volume together. And the residual volume, sorry. Okay, so then we're going to skip this slide. So if you would cross this off, please. This is advanced A&P. So all of these slides, we're going to cross off. So we get to here. This is page 452 if you use the middle numbers. So cross off those other slides. Page 452. Looking at areas of the brainstem, what controls those muscles? So I want you to know the muscles involved with breathing, quiet, normal breathing. And it's the diaphragm and the external intercostals. So the external intercostals and the diaphragm are in charge of breathing. And if you look at that worksheet, I think that was on there somewhere. Any other muscles that are used are called accessory muscles, and that's a sign of poor breathing, or maybe you're just going to cough or sneeze or, heaven forbid, drag on a cigarette. Then we use those extra accessory muscles. So So the external intercostals are the ones that are just normally stimulated by the brainstem. So the medulla is boss. So the medulla is what stimulates those muscles and the diaphragm via the phrenic nerve, right? And those intercostal nerves to stimulate the muscles of breathing, to contract, to move the ribs out and up and the diaphragm down to increase that volume. So that's the medulla. And then the pons helps switch, kind of tells the medulla to switch back and forth to stimulate and then inhibit, stimulate and inhibit. So what part of the breathing process is active, requiring stimulation? Is it inhalation or exhalation? What? Inhalation, yeah, because you need the diaphragm to move, it needs to contract, and the external intercostals need to contract to move the ribs up and out. So if you need contraction of muscles, you have to stimulate muscles to contract. But then we want them to knock it off and relax, we just turn it off. We inhibit that stimulation, and then everything goes back to resting length. So then we exhale. So exhaling is a passive process. Inhaling is an active process. So the medulla has most of the, when we talk about nerves and things going to these muscles, it's coming from the medulla out to the muscles. And then the pons is helping with switching between the two, between inhalation and exhalation. So when we start to inhale, the medulla neurons are active, and it sends action potentials to stimulate those respiratory muscles. And the respiratory muscles, again, are the medulla and the external intercostals. So if you haven't highlighted that anywhere yet, make sure you highlight this right here. Inspiratory muscles are the diaphragm and the external intercostals. So when a person has something like Lou Gehrig's disease or ALS, which damages the muscles where they have no muscle control, that is the end of their disease. That's usually what takes their life, is the diaphragm and the external intercostals no longer function. So then they have the decision to go on a ventilator, which will do the work for them, but they're never coming off. So once they go on that ventilator, they'll never come off. And that's a big decision that those patients make, is do I want to be on a ventilator, or do I want to call it quits when I get to that point? Because death is imminent with Lou Gehrig's disease. And except for that famous astrophysicist, what's his name? Did he just die recently? Hawkins? I forgot his first name. Stephen, is that what it was? Yeah. He had the longest case of Lou Gehrig's disease of any person that has been in the popular media. Normally, Lou Gehrig's disease takes one's life in about 10 years. It's a pretty fast-moving illness. So inhalation, we said, is an active process when the muscles contract, and exhalation is a passive process. So put an asterisk, star, circle, big arrows, flashing lights if you're able to on your laptop, so you don't forget that. All right, so then we're going to, let's see, how do we control ventilation? Ironically, carbon dioxide is the chemical that, when it builds up in the blood, that stimulates increased breathing. So carbon dioxide is a sign of metabolism activity, right? And if you're not blowing it off correctly, that's going to build up in your blood, right? If you have COPD and you can't exhale because of blown out alveoli, you're going to have a hard time. Or asthma with constricted airways, you have trouble exhaling. So you can have a buildup of carbon dioxide. And we know that carbon dioxide can turn into carbonic acid, which can drop pH. So anytime we have increased carbon dioxide, pH is dropping, and that stimulates the respiratory center, that stimulates the medulla to start to increase breathing rate. So to try to get rid of that. Oxygen levels have to drop to 50% or more in order to stimulate breathing. So the carbon dioxide level is going to increase before oxygen levels are going to decrease, because we have hemoglobin, and most of our oxygen is bound to hemoglobin. So if something happens that oxygen levels aren't available, we're going to just dump hemoglobin, or dump our oxygen off of hemoglobin. So that gives us a little bit of time. But carbon dioxide, anytime that's building up, again, with exercise, carbon dioxide levels will build up. If we're not breathing well and we're getting really fatigued, that's going to increase respiration rate. So it's a very sensitive system to make sure that we're getting our needs met and we're not building up carbon dioxide. So if things are working properly, we're going to blow off that carbon dioxide. So another thing is the cerebral, which is our thinking brain, and the limbic system, which is our emotional brain. We talked a little bit about the limbic system before. So if you're really angry, what's going to happen? You come home and you see this big mess and you're like, I am so upset. Did you need to breathe like that because there was a messy room? No, but that was the limbic system stimulating that heavy breathing. You didn't need it, right? Or you win the lottery, oh my gosh, right? Because you're all excited over that. Again, that's not a need by the body, that's just the brain telling you to breathe. So we can override that with our thinking brain or the emotional brain. But carbon dioxide levels building up is kind of that unconscious thing that should stimulate us to breathe. So when a person has sleep apnea, right, what happens? They stop breathing, carbon dioxide is building up, bam, they take that breath again, right? But that's not good. What's happening to oxygen levels during that time? They're dropping and dropping and dropping. So what happens, what does the body do when oxygen levels are going down? It constricts blood vessels to speed the flow of blood to our tissues. What happens to blood pressure if we have chronically constricted vessels? It goes up. So what happens with a lifetime of high blood pressure? What happens to the heart when it has to push under pressure over so many years of not wearing your CPAP machine and high blood pressure? It fails. It becomes weak and flabby, and now you have heart failure. And we cannot fix, we can give medicines, but we can't really fix a flabby heart. Heart failure is something that can be lifelong and a chronic condition. So we have to make sure we don't stop our breathing in the middle of the night. So people should get a sleep test and be diagnosed and wear their CPAP if they have sleep apnea. So if you have older relatives that are like, I don't wear that CPAP, it's a hassle. Ask them how their blood pressure is. Oh, yeah, it's not very good. Or I don't take my blood pressure medicine very well. Those are all signs of a patient that's going to have a shortened lifespan because of high blood pressure and heart failure.
Are CPAP machines more common now?
Mm-hmm.
The more people I know, especially like my grandparents or something, they have CPAP machines and.
Yeah. CPAPs are something that probably in the last 20 years, even 15, have become more and more common. People are becoming more aware, doctors are more aware of sleep studies and sleep apnea and the influence on that. Because people died of high blood pressure and heart attacks, back in the 50s and 60s much more commonly than they are now. Because we weren't looking at sleep apnea and we didn't know as much. And obesity is an epidemic. And obesity is directly linked to sleep apnea. Not everybody who has sleep apnea is obese, but a good portion of people who are obese also have sleep apnea. So that is another reason why it's more on the increase.
What inspires a physician to order a sleep study?
When a person talks about chronic fatigue and high blood pressure, chronic fatigue. Fatigue is a big one. When people say, I'm getting 9 and 10 hours of sleep and I'm always tired, they'll do a sleep study. Or snoring, and they'll ask, do you snore? Then they'll say, yeah, we'll do a sleep study, because snoring is often linked to sleep apnea. Yeah, we call it obstructive sleep apnea. So modifying respiration, if you look at the pluses and the minuses, one of these is the Herring-Brewer reflex. So what this does is this inhibits the respiratory center in the medulla and causes the lungs and the causes the muscles to relax. So it forces us to exhale. When the lungs become overstretched, that stimulates this neuron to inhibit the lungs, or to inhibit the muscles and allow the lungs to relax or exhale. So a person, you're exercising and you're trying to get more breath and you just can't get the breath you need because your lungs just exhale and you have to slow down, right? Or stop doing that activity. That's the Herring-Brewer reflex, preventing overinflation of the lungs. It's also, now Bridget, you had asked this question, it also is a primary role in how babies breathe. So if you look at babies breathe, they don't have the medulla and the pons, the nice little switching back and forth. They kind of go, right? They kind of make that newborns. You ever watch newborns breathe? It kind of freaks you out because you wonder, is that normal? And they don't really have that really rhythmic breathing as much because of this Herring-Brewer reflexes. It just stimulates them, keeps them a little more. Really? Yeah, because because just normal, because caffeine is a stimulant, basically. So it just stimulates them, because they say that, that SIDS, that risk of SIDS with premature newborns, is they fall into such a deep sleep that they just stop breathing. And there's some issue within the brain that they've linked to SIDS, but how do you know it's there until it's too late, right? Then you do an autopsy and determine, oh yeah, they had this abnormal brain lung connection that caused them to just stop breathing. So yeah, caffeine just keeps them more stimulated and they're not going into such a deep sleep. That's what I know, but there could be more to it than that. So again, when we're exercising is when this reflex kicks in. So that's a negative effect. When you move your muscles and joints, we can see that has a positive effect. Or when you step on something sharp or burn yourself, what do? You go, ah, ah, ooh, ah, right? You breathe heavily because of pain. And our patients breathe heavily because of pain. So oxygen levels drop when they're in a lot of pain. So those are all positive influences on breathing. Again, dropping oxygen, increasing CO2, those are stimulants of breathing. And our brain, what we're thinking, could be positive or negative, right? If I say, okay, I'm just going to relax, and then you just slow your breathing, right? Or you can get all cranked up and increase your breathing. So that's the higher thinking part. So we have chemoreceptors in the medulla and in the aortic arch and the carotid arteries that are measuring oxygen, and then the medulla measures that carbon dioxide. So again, this is the #1 controller of breathing. It's carbon dioxide levels. So when we exercise, just that movement of joints and muscles is a stimulant. It causes us to breathe more. It doesn't necessarily mean we need oxygen yet. It just means we're moving our body. And then after a while, you're going to see an increase, but then it kind of just gets into this normal breathing pattern unless you're overdoing it and your lactic acid levels are coming high. What is lactic acid going to do to pH if it's getting high? Decrease the pH, which is going to stimulate breathing again. So people with low pH are going to have a higher respiratory rate. So as we age, what can we look forward to? Our vital capacity, so the total amount of exchangeable air, inhale and exhale, goes down. We're not as able to move mucus from our airways, so our mucus is thicker as we age. And we have weak muscles for coughing. So that's why it's so important that we get our flu shots, because a person with influenza has a hard time clearing their airways if they're an older person with weak muscles. They can't inhale and exhale well. So as a result of that, they can't take a deep breath and they can't cough really hard after that deep breath. So that's why we got to really take care of ourselves so we're not bringing any nasty things to the bedside. Gas exchange across the respiratory membrane is reduced because the alveoli are less supple, less moisture, less ability to move gases. And then our residual volume and dead space increase. So that space where there's not, the dead space is in the airways. Air gets kind of stuck in those airways because there's less functional alveoli, and all that goes down. But we can have an effect on our breathing, and the best way to keep this at a minimum is to, the buzzword for the semester, exercise. Exercise with deep breathing. If you just say, I'm going to take my dog for a walk, and you're not deep breathing during that dog walking, that's not aerobic exercise. You're moving your muscles, you're burning calories, that's great, you're doing something. But if you really want to get good lungs and have good lung capacity, you need to take deep breaths and get that heart beating to get there.